Good day, everyone. Today I'm going to talk about fibrosis, a common pathway to organ injury and failure. First, we have to know what is fibrosis. So, fibrosis is defined as a disease-related injury in any organ that triggers a complex cascade of cellular and molecular response that culminates in tissue fibrosis. Now we're going to see a video about fibrosis.
So when I talk about what I'm referring to is scarring. So this can happen in response to an injury. So the body starts to manifest a wound healing process. That can result in excess tissue being deposited and also pulled and contracted. So rather than having healthy tissue restored, you can end up with a pathology type situation where the tissue is not quite as functional as that which we were trying to replace. Also different conditions, so for example with the ocular mucous membrane pemphigoid patients, they have an immune aspect to their disease, so they're more susceptible to this fibrosis scarring response.
As an example, we have that a heart is a soft tissue. When it is beating, it can extend and contract easily. But what happens if it becomes fibrous? It will be hard because the tissue is going to be too strong for the heart to contract and expand. Now we have a video about pulmonary fibrosis.
Idiopathic pulmonary fibrosis, or IPF, is a progressive and fatal form of chronic interstitial lung disease that eventually leads to the destruction of lung architecture and ultimately respiratory failure. The exact mechanisms by which IPF occurs remain unknown. Early hypotheses suggested that this devastating disease was caused by chronic inflammation that led to fibrosis. However, an increasingly favored hypothesis suggests that a still unidentified stimulus or stimuli produces repeated injury or insult to the alveolar epithelium, followed by an abnormal repair response that leads to unremitting fibrosis. Let's take a closer look. Despite the unknown etiology of IPF, several potential associated factors have been identified and include genetic predisposition, smoking, environmental dust exposure, gastroesophageal reflux disease, oxidants, and viral infections. The specific sequence by which the pathogenic mechanisms of IPF occur remain poorly understood, but are currently believed to begin with repeated injury to either the function or structure of alveolar epithelial cells. Once injured, the activated epithelial cells stimulate the release of several profibrotic and inflammatory mediators, including transforming growth factor beta and tumor necrosis factor alpha. TNF-alpha and other cytokines mediate recruitment of inflammatory cells, while TGF-beta and other growth factors stimulate the migration and proliferation of fibroblasts, which begin deposition of collagen matrix to initiate the repair process. Growth factors are also believed to play a role in the emergence of myofibroblasts from resident cells. Over time, these cells organize into clusters known as fibroblastic foci, where they continue to deposit extracellular matrix. The healing process becomes uncontrolled and dysregulated as matrix accumulates and the fibrosis becomes established. The dynamic balance between matrix synthesis, degradation, and resorption may become imbalanced, further contributing to the fibrotic process. The injured epithelium is unable to restore itself and becomes vulnerable to apoptosis or programmed cell death. In addition, the now exposed underlying basement membrane becomes disrupted, allowing fibroblasts to infiltrate the alveolar space. Conversely, fibroblasts and myofibroblasts fail to undergo apoptosis, resulting in continuous alveolar invasion and deposition of matrix, contributing to further destruction of normal lung architecture. The disease becomes more extensive due to repeated injury, each at different stages of development throughout the lung. This explains the temporal heterogeneous pattern interspersed with healthy lung tissue and the gradually increasing accumulation of matrix, unremitting fibrosis, fibroblastic foci, and honeycomb cysts that are the hallmark features of idiopathic pulmonary fibrosis. However, as our understanding of the underlying mechanisms of IPF evolves, from that of a disease resulting from chronic inflammation to that of one due to recurrent epithelial cell injury and aberrant fibrotic processes, our treatment approaches are evolving too.
So, there are many phases to reach fibrosis. First, we have the inhibition of the response, driven by primary injury to the organ. It's initiation of the response. Second phase, we have the activation of the effector cells. Next, this will be the elaboration of extracellular matrix, and then these extracellular things will deposit in a dynamic production, and finally the organ will be damaged and it will fail. The fact that diverse diseases in different organ systems are associated with fibrotic changes suggests common pathogenic pathways. This, when the response is orchestrated by complex activity within different cells in which specific molecular pathways have emerged. Cellular constituents include inflammatory cells like macrophages and T cells, epithelial cells, fibrogenic effector cells, endothelial cells, and other cells in the body. Now we have a video about tissue repair, regeneration, healing, and fibrosis.
In this video, we're going to discuss tissue repair. We're going to start the topic of tissue repair. It's a very long, lengthy process, so we're going to start this video by talking about regeneration, healing, and fibrosis. So, let's say you have a liver here. That's supposed to be a liver. And there are cells made up, they're liver cells, hepatocytes, that make up this liver. And it goes on and on and on and on. And let's say for some reason there's, some kind of problem where these cells are deleted. And now there's only this part. Well, this part right here, let's say chronic inflammation happens, acute inflammation happens, ischemia happens, some toxic drugs get in your liver and start eating away, this liver necrosis happens. Well, this liver's missing a part of itself. So what will happen is that the cells, these cells right here, are going to notice that they're at the end now, and they're going to be like, this ain't right. So they're going to initiate a cascade of tissue repair. And these cells are going to try to repair themselves. So if these cells can divide and repair themselves, then they will they'll go through the cell process of division, and they'll divide, and they'll try to regrow the architecture of this organ. Same thing in all parts of our body. After there's some damage, if the cells can divide, they'll try to rebuild that architecture, and they'll undergo regeneration. There's another part. Let's say that these cells, for example, these cells can't divide. So, example, can't divide, or they can't regenerate. Then healing occurs. Healing and fibrosis occurs. These kind of work together, if you will, and separately, but they're not mutually exclusive, but usually they work together. And in the case of pathology is concerned, healing means fibroblasts, these cells that are called fibroblasts. What they'll do is they'll be recruited to the area and they'll start laying down. This is the example that they can't divide, but then they'll start laying down just, you know, a mess of collagen and you know, scar tissue, and this process is called fibrosis. So they'll start just laying down a mess of this collagen to try to maintain its structure and, you know, maybe try to fill in this gap here, maintain its architecture, and you lose some function. When you have fibrosis happening, you lose some function in the area. And in the case of regeneration, where these regeneration, let's see here, is the example: cells divide, function and shape. I'll just put almost maintained. That's all equal to or almost equal to, not 100%, but you know, let's maybe say 99% of the time, or most of the time is probably the best way to say it. Most of the time is maintained. So in regeneration, you know, these cells divide. Most of the time the function and the shape is maintained. In the case of healing and fibrosis, these fibroblasts come in and they start laying down this matrix, if you will, this scar tissue, and you lose some function when this happens, because you don't have the normal cells that are working together, and the architecture is altered, and these fibroblasts. So we're going to talk about in later videos how well this is, how strong it is, how these scars are, and different things. So we will talk about that later. So that's it. In the next few videos, we're going to be talking about tissue repair, regeneration, healing, and fibrosis, and all the intricate details that have to do with when any part of your body gets injured after, you know, inflammation or some kind of injurious you know, stimuli to the tissues. How do these tissues
As fibrosis progresses, myofibroblasts proliferate and seize physical and biochemical stimuli in the local environment by means of interference and cell surface molecules. Contractile mediators trigger pathological tissue contraction. This chain of events, in turn, cause physical organ deformation, which impairs organ function. Thus, the biology of fibrogenesis is not dynamic, although the degree of plasticity appears to vary from organ to organ. There are many types of fibrosis. We have cystic fibrosis, lung fibrosis called pulmonary fibrosis that we see in the last video. We have liver fibrosis, heart fibrosis that we explained in the example, mediastinal fibrosis, retroperitoneal cavity fibrosis, and finally the skin fibrosis. We're going to see now a video about cystic fibrosis.
Cystic fibrosis is a chronic disorder that involves mostly the respiratory tract and the GI tract in the people that are affected by it. It's a genetic disease. That means that being a recessive genetic disease, you have to have two genes, one from each parent, to actually have the disease. If you're a carrier only having one gene, you don't have cystic fibrosis and you don't know that you're a carrier. Interestingly, about 5% of the population are carriers for the cystic fibrosis gene, but only about 30,000 people in the United States and North America have cystic fibrosis. In the respiratory tract, the mucus becomes very sticky because of a salt imbalance and a water imbalance, so that the mucus is not humidified enough. And because of that stickiness, it's more difficult to remove from the airways, and therefore it's a setup for having chronic infections with various organisms. A couple of the bacteria that are common in cystic fibrosis are Pseudomonas and Staph, and those bugs can cause some damage to the lung tissue eventually, and recurring bronchitis, pneumonias, and so forth, so that over a long period of time you can have some lung damage and eventually even require lung transplantation. The duct that leads from the pancreas to the gut is blocked in about 90% of the cases. That means that enzymes that help you digest food don't make it to the food, and so a lot of the nutrients are not absorbed well. That results in chronic diarrhea and poor growth. And so a lot of babies with cystic fibrosis don't grow properly, and that's how we find out that they have the disease.
Finally, we have the treatment. Although we understand many of the cellular and molecular processes underlying fibrosis, there are few effective therapies and fewer that target fibrogenesis specifically. These facts highlight the need for a deeper comprehension of the pathogenesis of fibrogenesis and the translation of this knowledge to novel treatment.
Number 8. New medications for idiopathic pulmonary fibrosis.
The lungs are the only internal organs that are exposed to the external environment and are vulnerable to a variety of ailments. However, when it comes to idiopathic pulmonary fibrosis, or IPF, death is a certainty unless the lungs are replaced. Idiopathic pulmonary fibrosis is a progressive disease isolated to the lung that causes scarring, thickening, and damage to lung tissue. Currently, more than 80,000 American adults have idiopathic pulmonary fibrosis, and more than 30,000 new cases are diagnosed annually. Life expectancy after diagnosis is usually 3 to 5 years, with patients progressively getting worse, most often because of respiratory failure. There is a new hope for patients with IPF. 2 experimental drugs that have been proven in large international studies to significantly slow the progress of IPF were just approved this month by the FDA. 2 new drugs in 1 year. People with IPF will finally be able to breathe easier.